Welcome to Straight to Why, which features conversations and insights uncovering the why behind the people, companies, and ideas transforming our world, with an emphasis on brevity to meet the needs of our busy listeners' lifestyles. On this week's episode, we are thrilled to feature Dr. Shelly Latte, who is going to dive deep with us into hormone replacement therapy, or what we now know as HRT for shorthand. Now, it's a treat to have one of the best specialists in New York City here to talk about HRT with us today. Midlife care is very necessary to support the health, well-being, and potential of today's workforce. And so if you're a cutting-edge employer, this is a topic where even if you don't think this applies to you, you should probably pay attention. Now, by way of background, Dr. Latte is a double board-certified physician who brings deep expertise in integrative midlife care, menopause and perimenopause, cancer survivorship, and lifestyle-driven primary care. A Menopause Society certified practitioner, she is nationally recognized for her work in mind-body medicine and non-pharmacologic strategies to support women through midlife transitions and beyond. Dr. Latte previously served as director of mind-body medicine at Memorial Sloan Kettering Cancer Center, where she piloted integrative approaches for cancer survivors, especially those with cancer-related menopausal symptoms. Dr. Latte, thank you, and welcome to Straight to Why.
Thanks for having me.
So my first question is, you have these incredible talents. Why have you decided to dedicate yourself to HRT?
Yeah, that's a good question because my clinical path is everything but intuitive or linear. I am just a regular board-certified internist, and my generations of physicians had no menopause care training almost at all, and no exposure to experts or expertise in this area. And so I sort of fell inadvertently into this topic. And, just by way of background, I, after my internal medicine training, I trained in integrative medicine just to, with my passion in non-conventional therapies. I then joined the integrative medicine service at Memorial Sloan Kettering Cancer Center, where I saw disproportionately I saw all cancer patients, but I saw many, many patients that were gynecological cancer survivors, breast cancer survivors, almost all of whom had menopause-related experiences. And they sought out integrative care because many of those symptoms were not well addressed. And so they ventured out to try supplements and alternative medicines. Many of these therapies weren't effective. Some were risky. They weren't evidence-based. And so I really was confronted with that vacuum of care that we know exists outside of the cancer setting for all of us, that many of these menopausal symptoms are not comprehensively or proactively addressed. And so, I became more and more interested in how to serve that specific sliver of that population, and more passionate, I guess. And
thank God. What does integrative medicine mean to you, just to ensure our listeners understand precisely what that means?
Yeah, so integrative medicine is the application of evidence-supported, non-pharmacologic, and non-conventional therapies, and to integrate them into conventional care. So, for example, in the menopause space, we have lots of evidence around non-pharmacologic therapies like cognitive behavioral therapy, mindfulness-based practice, hypnosis, right? These are all labeled as integrative or non-conventional, but they're evidence-supported, even guideline-supported treatments that can be incorporated into conventional care.
But it's very challenging for the consumer to know what's what.
Correct. Absolutely.
So why do you think, in terms of just society being comfortable talking about it at large, but why do you agree with that premise, and why do you think that's changed?
Yeah, I think that many reasons why it has become such a popular topic on social media and just in the public discourse. I think one important reason is a cultural reason. I think that this generation of midlife women has become a lot more comfortable, a lot more vocal, a lot more unapologetic about pointing out the gender-based inequities and challenges that they're facing in their health. And it's sort of the same cultural push that we're seeing that makes conversations about sexuality and periods and contraceptive choices or reproductive choices much more visible. That's the same cultural push that also removes some of the stigma of shame around menopause and makes it a lot more, it pushes it into the public discourse. And so I would like to say it's, it sort of the renewed attention in menopause is something that was fueled by experts and physicians, sort of realizing, geez, we're really not doing that very well, midlife women's health, and then paying more attention and putting more resources into that area. But it's the opposite. It was a bottom up, women saying, we need better care. We cannot put up with these symptoms. We don't want to toughen it out. We need better care. And that's what fueled a lot of that, I think. And of course, we have better data, better clinical guidelines that have taught us a lot about how to use menopausal hormone therapy more appropriately, more safely, and who would benefit most.
And that's a good one to jump right into because we very recently saw that black box removal as it related to HRT. And I'd love to get your perspective on what you think that means and why that choice was taken to make that change.
Yeah, so I think that was an important change. The FDA removed a lot of the black box language, the most severe black box language from estrogen products specifically. The most appropriate product where it was removed from, the most important and significant change was in topical low-dose vaginal estrogen, where a lot of the warnings that women sort of got it prescribed, they were told this is completely safe and they apply it twice a week, intravaginally, and, there's no problem with that. And then they open the package insert and it warns them of cancer and of blood clots and of strokes. And that was completely inappropriate because we know that this is a product that does not get systemically absorbed in any significant amounts. And so this is not something that happens with that product. And so removing that was a very important update by the FDA. Now, hopefully, this will lead us to seeing maybe less hesitancy around the use of this product and making it more accessible to patients, making clinicians more confident in prescribing it. That doesn't mean, however, that menopausal hormone therapy is without risk. And so I think there's a lot more to say about the removal of the black box warning for all other systemic estrogen products. I think we have to wait and see what this is going to be replaced with.
And what are some of those risks?
So overall, I have to say that risks have been historically overstated and overblown and misinterpreted. And because this is an underprescribed drug, I often talk about the risks that sort of were overblown and misinterpreted. There is a small risk for increased risk that is related to clotting and clotting disorders, that is related to bleeding, uterine bleeding, that is related to breast cancer risk in specific populations that are at higher risk. These things have to be talked about, but have to be talked about in a very personalized, individualized way, right? So this is not something that broadly should cause fears or hesitation about this treatment. There's a very important role of the clinician to unpacking your individual risk profile and also the reasons why you're seeking out menopausal hormone therapy and weighing them against the small risks of this treatment.
To that end, what are the signs that you look for when a patient comes to you to say, yes, I do think you're the right potential person to receive hormone replacement therapy, or where you say to the candidate, let's explore other options because I'm not sure that it's hormone replacement therapy you need, or to your point, you may be too risky of a profile for it or certain types of hormone replacement therapy?
Yeah. So let's talk about the ideal patients and some of the contraindications. So the ideal patient would be a woman that is experiencing symptoms, which we call vasomotor symptoms, so hot flashes and night sweats, and or genitourinary symptoms. And we can unpack these symptoms in more detail. And women that also have a high risk for bone loss or a existing early bone loss or osteopenia.
Oh, that's
so for
interesting.
bone
I didn't know that.
protection.
Okay.
So these are the indications for menopausal hormone therapy, and the ideal time frame of starting menopausal hormone therapy would be in a woman that is less than 10 years away from her last menstrual period or under the age of 60 and doesn't have overt contraindications. That would be sort of the ideal patient.
Is there an age where you expect to see someone, or does it vary widely?
It varies widely. I think the average age of menopause is around 51 years old in the US. Globally, it's a little bit earlier. It's maybe around 49. But it's normal to have the last menstrual period be between the ages of 45 and 55. So that is sort of a normal time window. Now, perimenopausal symptoms can occur up to 10 years before that last menstrual period.
Important point.
Exactly, because many women in their late 30s may show up with early signs of perimenopause, and those often have the biggest challenges in really identifying what is going on.
It's really interesting. And then I want to go back to the cancer point for a minute.
Yeah.
I have a lot of friends who have had breast cancer, and one of them was actually visiting me this past weekend, and she said to me, it's so exciting and energizing to see hormone replacement therapy being discussed for women today in the way that it is, and it wasn't historically, but it leaves breast cancer survivors sometimes feeling completely left out of the picture and without necessarily all the help and options that are available. I know in her specific case, she could not do hormone replacement therapy. That was the determination of her physicians. But what other options do breast cancer survivors who can't take hormone replacement therapy have to deal with some of these menopausal symptoms that hit them really hard and quickly?
Yeah, so that's a population that's obviously close to my heart. I see a lot of patients that are undergoing cancer treatment or in cancer survivorship. And as I pointed out, many of the deficiencies we see in the general population in menopause care are a lot more emphasized in survivorship. And so, yes, several gynecological cancers and hormone-sensitive breast cancers are classic contraindication to menopausal hormone therapy, alongside with other contraindications. So there are, and I have to say, none of these contraindications are hard stops. So I have in my clinic patients that have these contraindications that I'm going to name, and I still started them on menopausal hormone therapy. It's just that these women need a lot more personalized, individualized, nuanced risk-benefit conversations around the use of menopausal hormone therapy. But yes, so these hormone-sensitive cancers, uncontrolled cardiovascular disease, a recent clotting history or clotting disorder, uncontrolled liver disease, or sort of an unknown reason for uterine bleeding. These are the contraindications that we usually speak about. Again, these are not hard stops. But when women are confronted with contraindications, there are a variety of different options that we can employ. Number one, for genitourinary symptoms, they can still often use topical low-dose vaginal estrogen.
Okay.
And sometimes I have to overcome some of the fears around estrogen to ensure that they know that there's an abundance of data that documents the safety in almost all women.
And that goes back to your black box warning too,
Yes.
right? That's one that it sounds to me like is localized. So maybe it's not such a systemic risk to take.
Correct. And so that is one treatment that we can often easily start on, and it improves quality of life and is very, very meaningful in this population, especially in breast cancer patients that also receive anti-estrogen or estrogen blocking treatment and that have more severe genitourinary symptoms sometimes, right? So these women have to be, it's still a conversation that is a lot more involved than with the general population, even when it comes to vaginal estrogen, because some of the treatments that they're on may vary or may determine what kind of data we have about how to apply vaginal estrogen, but it's not contraindicated and can be used. And it's often the first step that we can take. Now, when it comes to hot flashes, there are a number of non-hormonal treatments that we can prescribe. Examples are SSRIs and SNRIs. These are medications like Effexor or venlafaxine, medications that are usually used for anxiety and depression.
They're antidepressants, right?
Exactly.
Okay.
And so in low doses, they can be effective in treating hot flashes. There are other medications like gabapentin or oxybutynin, which is a medication that's usually used for overactive bladder. And also treats hot flashes quite well.
Oh, interesting.
And then there are newer medications like Veoza that are specifically designed to treat hot flashes in a non-hormonal way. These are Neurokinin 1, and there's also a newer medication on the market, or not quite on the market now, but is going to be on the market, Linquid, with a Neurokinin 1 and Neurokinin 3 inhibitor that can help with hot flashes and sleep.
What does that mean? What inhibitor?
So this works centrally on the temperature regulation system in the brain.
Okay.
And here, some of these receptors are dampened in their effect by estrogen. And when estrogen goes away, the temperature regulation goes more haywire. And so women are more prone to experiencing these hot flashes. And so these inhibitors, these drugs specifically inhibit these receptors. And with that are a very specific targeted treatment to address hot flashes in a non-hormonal way, centrally, where temperature is regulated in the hypothalamus.
That's helpful, because I don't know that all of my listeners would understand that.
Yes, of course.
And I do think that the idea that even if you cannot necessarily take precisely a systemic estrogen or progesterone or other hormone-related treatment, that there are options, I think is something that's really important for breast cancer and other cancer survivors to understand.
Yeah, I think what's important for these populations is to know that there is a more comprehensive approach needed. Right here is where we want to apply some of the non-pharmacologic treatments. For example, here's where integrative options become a lot more relevant.
Right.
And it becomes also more relevant to have a team approach, right? Where your oncologist is involved, your gynecologist is involved, a sexual medicine specialist is involved, maybe even a pelvic floor therapist is involved, and the menopause specialist, and all are in conversation and addressing these symptoms comprehensively, proactively. Here, that team-based approach is really important to really make a difference.
That's interesting. Who leads the team? Is it a general care provider that someone should go to first to say, I need help me get started? Or are they better suited going to someone like you first and saying, here are my symptoms, what do you recommend in terms of an integrative program for me?
So this is really aspirational, that team. I think that this is not something that's happening routinely. This is something that sometimes comes together and is then very fortunate for these patients.
Because very few general care providers, let alone traditional OBGYNs, necessarily understand or want to dabble in hormone replacement therapy.
Yeah, and I understand them. It's true also for oncologists. As much ownership as they have of their patients, they don't have the time to sit down and have these very comprehensive risk-benefit discussions with patients and really present them with all the different options and then modify the treatment as they monitor the response. This is something that takes time and is not it really exceeds the space and the time that these practitioners often have.
I can understand in the context of being, deeply concerned about the patient's survival as being the primary issue.
Yes.
But then quality of life really quickly comes into play. So I like that aspirational idea of a team approach.
Yeah.
And I'm going to interpret what you said as go to you first, because I think otherwise finding the right team could prove really challenging. And someone who has your experience working with other providers will know better places to go versus not. But I understand your point that it doesn't quite work that way today yet. And let's see when it does. It might take some time. Now, I want to talk a little bit specifically with you about digging a layer underneath, which is the three primary hormones I think of, which is estrogen, progesterone, and testosterone. Maybe there's something I'm missing. But what role do each of those hormones play in the female body?
So obviously these are sex hormones that are usually associated with reproduction. However, all of these hormones really have receptors that are in all our organ systems. And with that, we can conclude that many different actions that are taken by these hormones are felt all over the body.
Sure.
And when they wane, when the levels go down in midlife, that is what triggers the myriad of symptoms, what I call the symptom suitcase that many women present with, right? And so I think that let's start with estrogen. Estrogen is one of the most varied and multitasking hormones in the body. There are receptors from bone to brain everywhere in every organ system. When we're thinking about the reproductive system, estrogen is, of course, tasked with regulating the menstrual cycle and fertility, also taking care of the vaginal tissues, elasticity, lubrication to some degree. When we're thinking about bone, limiting bone turnover, having a strengthening effect on bone. When we're thinking about metabolism, having actions in fat metabolism, that estrogen is tasked with. When we're thinking about the brain, estrogen interfaces with serotonin and dopamine pathways, regulating mood, right? So we're seeing that the actions here of these hormones and the activities of these hormones are very, very varied and really affect the whole body. And that's how we see that in midlife, we can suffer when these levels go down. Now, progesterone is a hormone that is often associated with pregnancy alone, but it has a lot more roles in the body. For example, in menopausal hormone therapy or in our reproductive cycle, progesterone really has sort of a countering effect on estrogen. When estrogen really helps with thickening the endometrial lining, progesterone stabilizes the endometrial lining and doesn't allow it to proliferate uncontrollably when we're giving a woman, for example, exogenous estrogen. But it also has central activity. So it interfaces with the GABA receptors. GABA is a neurotransmitter that is often associated with sedation and sleep, and maybe sort of has a dampening, slightly cooling effect on mood, right? So it also has an impact on sleep drive. For example, has a stimulating effect on sleep. And a breathing drive.
Because I do know some friends who've said they've had bad anxiety with low progesterone.
So because of its effect on the GABA receptor, taking away progesterone can have this impact on being more activated or more, agitated, irritable, which then exogenous progesterone sometimes can be benefited from.
Okay. Yeah. And so I got my last question for you is, it's really a macro question, but I really don't understand why so little funding has gone into hormone replacement therapy and research in general as it relates to women's health. And it's something that I'm personally passionate about. I'm a private investor in some of the venture capital funds that are working on some of these issues. I really can't fathom how you can have a workforce that is so fully comprised of women, not as much as it should be, but there are plenty of women in the workforce. They can't stand to lose 10 to 15 years of productivity because of not feeling well. And what you think needs to shift for funding for research to move more in this direction to help alleviate some of these issues for more people?
Yeah, I love this question, especially because there's so much data around how there's data out of Britain that came out that was really shocking.
It was shocking.
Yeah. So the impact on cognition, on productivity, so just on perceived abilities of these women to cope with their daily tasks, very competent women at the height of their career, right?
And peak of their earnings potential.
Yeah. So why is there not more research? I think there are various reasons. One of the reasons is maybe to some degree a gender-based deprioritization of midlife women's health. I think we have to say that out loud, and this is something I believe I witnessed, and it is still coloring some of the distribution of research funding. But there are other reasons as well. We talked about how varied the effects of these hormones are and how complex hormone biology is. That is why study design is a lot more involved in these areas. And to top it off, I think that studying outcomes like cancer risk or cardiovascular risk takes many, many years.
Right.
Large observational studies that are very, very long and involved. This is a lot more complex. And
it will take time.
It will take a lot more time, a lot more funding. And I think there's also hesitancy because of the history in the shadow of the WHI, the large group of studies that was published 2 decades ago that was largely misinterpreted to the public and really caused a lot of damage in the way it was presented to the public.
And you're referring specifically to one of those initial reports that came out and said, this is paraphrasing probably unfairly, but essentially most hormone replacement therapy increases cancer risk.
Correct. Yeah. So the study was interpreted to the public in a way that was overly globalizing some of these observations, right? And overstating some of the risks or stating them and not explaining them well. This was a study of mainly older postmenopausal women on very specific forms of estrogen and progestogens that we're not using as commonly anymore in these forms and in these doses. What has been taken away from these studies was basically menopausal hormone therapy causes breast cancer, increases
runaway
stroke. Exactly. So
right.
It caused a lot of hesitancy and rejection of this treatment, which deprived generations of women from this very safe and effective treatment. And I think that has also created some hesitancy in the research community to turn around and tackle such an immense project again.
And if you I know I said it was going to be your last question, but I have one more I have to ask you. If a woman is considering seeing a specialist about hormone replacement therapy, what's the number one piece of advice you have for her? What should she think about first?
So the first thing I would say is track your symptoms. Track and observe your symptoms. Especially in perimenopause, you might observe that there are cyclic symptoms that have sort of a cyclic pattern and makes it a lot easier to relate that to hormonal activity or to a hormonal reason, right? So this is something that's very, very helpful in your first encounter. Number 2, don't talk yourself out of symptoms. So sometimes symptoms are mild or moderate, and maybe you're not sure if these are hot flashes or not. I find that women have a really high tolerance towards suffering sometimes.
Well, childbirth will do that to you.
Yeah, exactly. And so I sometimes see people talking themselves out of seeking out menopausal care because they think it's not, it doesn't deserve that kind of attention. But when they get it, it makes such a big impact on their quality of life and overall wellness.
That's such a shame because women really are the center of the home and the workplace, and we do so many things that the notion that we somehow would think that we don't deserve to feel relief from these symptoms really needs to be eradicated and quickly.
Absolutely. It's not only the center of the home, it's really of society, right?
Correct.
A lot of the public health data shows that
home, center of work, center of society, friendships. There's so many things that women do that power our economy, that power our world, our children, everything. So the idea that women are intended to suffer is something that just falls very flat for me.
Absolutely. Yeah. And then the third thing I would say is make sure your health is regarded in a holistic way, right? What we're seeing now with this increased attention to menopausal hormone therapy, I don't want people to sort of get thrown at some menopausal hormone therapy and then sent home, when really in midlife, we want to look at all the different reasons that can cause symptoms. So for example, if you're having sleep disturbance, yes, these things can be mediated by a change in the hormonal environment. But you could also have, severe iron depletion with restless leg syndrome. You can have obstructive sleep apnea and not know about it, right? So this joint pains, mood changes, these are all things that are usually multifactorial, that are not always resolved and are really not indications for menopausal hormone therapy. And so in midlife, many of the risk factors show up first, right? Many of my patients see that their cholesterol is going up for the first time, or some of their glucose metabolism numbers are going up for the first time. This needs a comprehensive, wide-angle view on their health in order to really benefit from midlife care. And that is not limited to menopausal hormone therapy. That has to be looked at broadly.
Well, doctor, thank you so much for joining us on Straight to Why. I learned a lot about hormone replacement therapy. I think your mind, knowledge, and experience is probably endless, so I could have spent at least another hour and a half with you. But keeping true to our time limit, I'm very grateful you could be here. Thank you so much, doctor.
Oh, it was a pleasure. Thank you for having me.